Morning, ladies and gentlemen. Good morning. Good morning. Welcome to Worcester Cricket Club. I'm Karen Davey. I'm here to facilitate the workshop today. If anybody gets cold, please give me a shout, and we'll close the door. There's some toilets just on the left-hand side if anybody needs a natural break. Delighted to introduce you to our speakers this morning. We have Jacqui Fletcher with us. Jacqui, I'm sure you'll all know Jacqui, patron of the Leg Club. She's been in the field of tissue viability for many years, working as a clinician and also as an educator, leading the Bachelor of Science and the Master of Science at the University of Hertfordshire. She now works as an independent consultant and is a clinical editor of Wounds UK. Also delighted to have Magnus. Magnus, I should have asked you how you pronounce your surname.
Lysemose, Danish pronunciation.
Okay,
Yeah.
we have Magnus. That's dreadful, 7 years in Sweden, Taxonica. Magnus is the Chief Operating Officer of Nordic Health Group, which is a Danish company. So Magnus has flown in from Denmark yesterday to be with us. A company with over 30 specialised varicose vein clinics in Northern Europe. He started more than 20 varicose vein clinics and is involved in developing an internal research entity within the group with a focus on varicose veins issues. So this morning we've got 45 minutes with you. This workshop's going to look at some of the international guidelines and address the recommendations and comparison amongst different nations. Jacqui and Magnus, thank you.
Thank you. So good morning everybody, welcome. Delighted to see you all here on time. It's not always easy being in the city centre. Hopefully you all parked well and are looking forward to today. It seems a strange topic to start with nursing staff, is guidelines. So can I just check, are you all nurses?
Yes.
Are there any podiatrists? Was going to be my next question. So there's some podiatrists. Hospital, anybody? Or community? Yes? Commercial, okay. Yeah. Some commercial. And we're starting with guidelines for a reason, because I think hopefully now we are all trying to deliver evidence-based care, and that should come from the guidelines. And just before we start, we both have to say that this is consultancy work, this is our own opinion, this isn't influenced by the people we work for. So the role of a guideline is to summarise the evidence base. None of you in this room have the time to read every piece of research. I would also say you probably don't have the inclination to do that. You have busy jobs, you have certain things you're interested in and some things that you're not interested in. So guidelines do that summary of the evidence base for you. And what we're aiming to do is to standardise practice. You will know across the UK we have this thing called the postcode lottery of healthcare, and depending on where you work depends on what services you may have. So if you think about, we're here for leg clubs. How many of you got a leg club in your area? 4 of you, 5. So less than half of you. Some of you may have specific leg ulcer clinics, some of you may have community podiatry clinics, some of you may have none of those. And you may just have a community nursing service that is trying incredibly hard, but really not making progress. But what we all want to do is improve our patient outcomes. At the end of the day, I think that's why we all go to work. So just a question, if you have a local leg ulcer guideline, or if you're going to write one, what would you think would be in it? What would it be about?
The patient.
The patient, it's a really good start.
Safety.
Safety.
Risks and management.
Sorry?
Risks and management.
Risks and management, yeah.
Best practice.
Best practice.
Compliance.
Compliance. What would it start with? What would be the start point? How would the patient get to be in the guideline?
Assessment.
Assessment of what?
The whole of the patient.
Everything. Okay. But generally speaking, do most of our leg ulcer guidelines start when the patient gets a leg ulcer? No? Where do they start? No.
At the time the leg ulcer.
What? So where did your
Sorry,
leg?
I don't think I heard the question.
Oh, don't worry. I was very interested because I want to start with this. So my background is primarily in pressure ulcers. That's my passion. So I don't like leg ulcers, but my passion is pressure ulcers. And we did some work thinking about the different pathways we've got. So in England, is anybody not from England? Anybody from Wales or Scotland? Okay. In England, as you know, we've got a national wound care strategy that has 3 pathways: pressure ulcers, lower limb and surgical wounds. And we tried to be standardised, we tried to do the same. But when we looked across the pathways, we realised we weren't. And I was told in pressure ulcers that pressure ulcers didn't need as much attention. You've all read the burden of wound paper, guest, that says how much we spend on wounds. And 41% of what we spend is on lower limb. Huge amount of money, large number of patients. And I'm told pressure ulcers don't need the priority because only 7% of the patients with chronic wounds have pressure ulcers. And I'm really proud of that. That's because I start here. I start with prevention. In leg ulcer care though, we wait until the patient gets a wound. Now if you use pressure ulcer language, we say if a person gets a pressure ulcer, they've got a harm. Don't we? It's a preventable harm because there are risk factors. Are leg ulcers preventable?
Yes.
So why don't we talk about this being harm and step back to here? Think about your local guidance, whether it's on a foot ulcer. So foot ulcers, DFUs, they do a lot more of this, same as pressure ulcers. Let's look at a patient with diabetes, start teaching them about their feet. Pressure ulcers we start with, but not with our leg patients. And if you look at the guidance we use, so although we are in England, there isn't NICE guidance, because NICE looked at the Scottish guidance and said, that's really good, we're not going to rewrite it. Which is sensible, isn't it? It's our tax money. However, they haven't updated it since 2010. We're fighting really hard. NICE have in principle agreed to do a new guidance, but they've not got round to it yet. And if you think about what that says, it says start in the middle of the pathway. We've also got from National Wound Care Strategy. So how many of you have heard of the National Wound Care Strategy?
Yes.
Everybody. That's really good news. Have you all got this in your practice? So this is the pathway. So this is the translation of the guideline into what can I do, what should I be doing with my patient. And it basically says that the first person to do an assessment should think about these big risks. If somebody's got sepsis, don't start fiddling about doing a Doppler and compression, get them to a doctor. I think we all think that's sensible. But what's really different is this bit down here. If they haven't got any of these, even if you can't do a Doppler, put them in compression. Now we know for a lot of people that makes them go, ooh, what if the leg drops off? Because we've always been told that, haven't we? Don't compress until you've done a Doppler. But this says use mild compression, so up to 20 millimetres of mercury. It also says within 14 days get a proper assessment. Now, I won't ask if your service delivers that because we know it's aspirational. We know it's what we're working towards, and we know about the community nursing crisis and the lack of staff. But people are trying to achieve this. And it gives you something to go back to your managers and say, we should be doing this. So we talked about that bit before the pathway. We talked about those risk factors. Do you think it'd be helpful if there were a risk tool? You know, like we've got Walton or Braden or Purpose Team. Would it be helpful to have a risk assessment tool like this? So, you know, patient pre-ulcer, we might need to think about risk. Do we already think about risk factors when we manage a patient with leg ulcers already? Think about your assessment form, that holistic assessment that you do. Do you look at past medical history? Do you look at how many pregnancies? Are those risk factors?
Yes.
But you don't think about them in that way. You think about them as it's on an assessment form. So again, this is the form from National Wound Care Strategy for referral into vascular services for venous referral. And you can see it starts with some screening questions, so it repeats those red flags. And it starts to get you to think about, once you've done your demographics, signs of venous disease, risk factors. And then on the last page, it actually says, these are the risk factors for venous disease. So this is making a presumption that this person needs to be seen by a vascular surgeon for treatment of the underlying cause of their leg ulcer. But actually this referral form waits until they've come into your care for a venous leg ulcer. So what's stopping us taking that and using it beforehand? How many of you are like me? So I'm terrible. I will be walking around the supermarket and you just get like this done. Seeing that plate, I wonder if she knows about compression. Oh, look at the colour. But we do that, don't we? Yeah. Why can't we say to that? We're not in the supermarket, obviously. But if you're seeing that patient for something else, why are we not saying, what are you doing about your legs? You could be moisturising your legs. You could be using compression on your legs. Can you do some exercises? And that would help us reduce the number of patients with venous leg ulcers. So, what more do you think we could do to help to identify patients with venous disease rather than venous leg ulcers?
look at the not comorbidities, but the risk, as I say, for pregnancy, and educate them at that level and get them into compression before they develop. So cardiac failure, anything that's a risk factor for venous disease.
So think about all the touch points we have with patients that we class as risk factors. So you mentioned pregnancy. Anybody in this room had a baby? Do you remember being told about wearing compression, or that this is your fourth child, it might increase your risk? Anybody in your family had cardiac surgery? My ex-husband had coronary bypass grafts. Put me in TED stockings, but nobody said you might benefit from compression because we messed with your plumbing. So maybe now think about compression, and do you know what? He gets really swollen ankles. When you see those patients with the cardiac surgery, how often is it the donor site that the wound is a problem? Why don't we compress them? Do you still get told if a patient's got heart failure not to compress because you worry about overloading the heart? That's not true. There's a beautiful document in there that tells you about compression in heart failure, but how that actually helps the patient. So there are lots of things that we could think about that. And is it the same in the international guidelines? So what guidance do we have about preventative care? So we've got all these guidelines. So we've got independent European guidance, we've got European College of Phlebology, can't say the word, phlebology. We've got the NICE UK guidance, I'll show you in a minute, American Venous Forum. And once they're all localised to how care is delivered, to what services you have, what's really common in them is this consensus that patients with symptoms of venous disease should be referred for and have access to endovenous ablation as a first choice. So the form I showed you from the National Wound Care Strategy was for referral in for endovenous thermal ablation. And what it really is focusing on is that early treatment of the symptomatic varicose veins from the patient perspective. So does that work in your service? Why not? Why do you not do this?
Funding a lot of the time. We have to apply for funding for ablation.
Right.
So the vascular department haven't got that kind of capacity to see patients, and that's what we have trouble with.
Is it the same for everybody else?
So it's a capacity problem and
No,
funding
we
problem.
do refer direct to vascular for ablation.
Okay.
We were a tranche site to do
So
their
which FIB do you? Which FIB are you?
Hereford.
Hereford.
Yeah, so that form that you've shown, that's the very form that we
So you work with Lucy?
Yeah,
Yeah.
yeah.
So within the National Wound Care Strategy, these are the 7 sites I talked about where we're testing things. And so yes, and one of the things that came out from some of the sites was that complexity of getting to the vascular teams. You can use the form, but if there's nobody to do the surgery, or the surgeon's not interested, or the GP won't sign it off, you have your problems. So that recommendation that the National Wound Care Strategy have made in that pathway and in that form comes from this document, not from venous leg ulcers. There's nothing in the sign guides about leg ulcers. It comes from the varicose veins up the leg. Nice guidance. And this is their criteria. This is the recommendation that we base it on, that we refer patients to the vascular service if they have symptomatic primary or recurrent varicose veins. Has anybody in this room tried to get a referral for varicose veins? Yes? How did that go?
Not well, because they consider it cosmetic now. Not for me, but for my eldest daughter.
How old is she?
She's 45.
So she's not old.
No, but we've family history of really bad varicose veins, like my dad and all my aunts and uncles. And eventually, with a lot of fighting, we did get her in, and she had surgery. But it made the world of difference to her because she was in so much pain. But I do have her in compression, and she's very compliant with her compression. But it's ridiculous, really, when you think we class a lot of these things as cosmetic, yet by not treating them at an early stage, the other comorbidities that occur end up costing the NHS way more money.
And you mentioned some really important things. You talked about they see it as cosmetic. You also talked about family history.
Yeah.
And one of the things that both Magnus and I were talking about, even in Denmark, where they have really good referral criteria, people don't present because they expect it. Everybody else in the family's had it and they don't get treatment, so why would they be treated any differently? And that's a really important thing about patient perception about what can be done, isn't it? And we have this tension really in what you described between what the clinical evidence says, what the medical evidence says works, and that, you know, we know long term it will give us savings. If that patient doesn't go on to get another disease, it will save us a huge amount of money. But what the people who are paying for the care will fund and are prepared to deliver, and they're often not the same, are they? You know, and that, you know, what your organisation, so your local acute service will be saying to you, no, we don't have that. We're not funded. We're funded for life-saving work. We do arterial surgery. We do the really exciting things. We don't do the venous surgery. It's cosmetic. And you have to really fight to get that seen. So just looking at some of the ways then that we can start to speak a common language, that we can start to think about referral criteria for people. So can I ask, how many of you have seen SEEP? One, two nods? Not many. So this is a tool that's used internationally, and it identifies the progression to higher clinical stages. And it focuses on the clinical much more than the underlying etiology, anatomy and pathophysiology. You may see it used in your vascular teams. So vascular teams tend to use it more than clinicians. So I'm guessing most of you working community, you've not got this in your documentation. But it's an internationally recognised way of looking at legs before they become leg ulcers. So I mean patients obviously, but you know, about looking at that at-risk population. And it can be used as a referral criteria. So you can see here across Europe, in the UK, we don't refer until the patient is at 3 or 4. So if you go back up here, this is showing they've got the edema and all the skin changes assigned to venous disease, not when you've got these early disease things. And whereas in Denmark, you can make a referral at SEEP2. So that's a much earlier recognition and management of those presenting symptoms, hoping to take patients out of the system, down the pipeline. And Magnus was telling me, as I said earlier, that even though that's there, a lot of people don't get referred because they don't present for referral. What is missing from SEEP is the clinical symptoms. So if you talk to patients, if you've got family members with lower limb problems, they might talk to you about the look of the varicose veins, they might say they're ugly. But generally, what they talk about are the symptoms. And those symptoms include things like tingling, swelling, pain, heaviness. So we typically talk about heaviness with venous leg ulcers, don't they? They have heavy legs. And that's what compression helps get rid of because it gets rid of the fluid. Itching, to me, is the most under-recognised symptom. If you've been on holiday and you've been bitten by some nasty stingy thing and it's itchy, is that the worst thing ever? Does it keep you awake? Does it drive you mad? Would you rather have pain or itch? It's a close call thing, isn't it? But how many of your leg ulcer assessment forms include itch?
Itch is a mild form of pain.
It's isn't it? But there's no box for itch. And if you ask a patient about pain, they won't tell you about the itch. Do you remember in the literature we used to talk about patients with knitting needle syndrome? So they have the compression on, and we used to say elderly patients in the community used to stuff knitting needles down so they didn't get socially isolated. Why do you think they were scratching their legs? They were itchy, weren't they? Cramps. If anybody wakes up in the night with cramps, it's the worst thing ever. And burning sensation. So there's a whole range of symptoms that we could start to build into a clinical assessment that's not there that we need to think about. There is one tool that does include this. So this is called the Venous Clinical Severity Score. I know it's not very clear on there, we're going to hand it round to Tara, so we're going to look at them a little bit in a minute. And think about, actually, would this be useful for you? So if you are seeing people who have problems with their legs, this allows you to look at this list of symptoms and show that they're progressing from being absent to mild to moderate to severe. You know, so if you've got a vascular department who's saying we're under great pressure, You can start to classify people a little bit and say, actually, this patient's much worse, this person needs help more. And that might be a really useful thing to do. So we need to think about this discrepancy between what the clinical need is, what the clinical evidence-based recommendation is, and our ability to pay, whether that's like the NHS or in Europe, maybe it's a insurance-funded type thing. And the pressure that puts on the clinicians, because I don't even think the vascular surgeons think it's a bad idea. I think they want to do the surgery, they just don't have the capacity, and they know that they won't get funded for that work if it's done. So we have this tension about venous disease care being suboptimal. We still have, I think, a lot of misconceptions, so people get a lot of misinformation about what they should and shouldn't do, what they can and can't have. You can't have treatment because it's just cosmetic. It's very common. And they're not being referred into specialists. And there's a huge impact on their quality of life. Huge impact on their quality of life. And you see that with the varicose veins, you certainly see it when they get their levels, which is what we're trying to present. So this then has a huge impact on resources, whether that's yours or whether it's the dressings and bandages we use. Think about that in terms of sustainability. You know, we're trying really hard now with pathways to drive down the number of visits, to drive down the amount of bandaging and dressings, because there's the amount of waste that goes alongside that. So there's the travelling, there's the stuff that you use and how that's made, whether it's imported or wherever it's from, there's the waste management. If we can prevent all of that, it's a huge contribution to our net zero policies. And we know that venous disease consumes up to 2% of public healthcare budgets currently. Are your patients getting older? Definitely, aren't they? How many patients have you now got over 80? A lot. You know, it used to be over 60, didn't we? So we've got a few people in the 70s. Now we've got a few people in the 90s and well over 100. So we know that can only get worse. So we want to get you into groups now, so into 3 groups of 4, just to talk about. So we've got 3 tools we want you to look at. And we've got some questions that we want you to address. So we've got 2 versions of C. One's got pictures, one hasn't. But also one's got an extra category. So we want you to have a look at that. We've got the scoring system. And we've got some questions for you. So we can pass those out, and we're going to give you some post-it notes as well. So let's give you, please don't take these away because these are going to last us all day. And we know what people are like the station, what that was. So some of some post-its coming in. Is it useful to look at those tools? So I heard some conversations about, well, that's a lot of information, it's quite detailed around the varicose vein, about symptom 1. And you could give that to a patient, couldn't you?
Yeah,
You could ask a patient to do it for you.
Yeah.
And that's a great way of shared care, patient engagement, getting them to think about what they might do. A couple of people saying they liked the visuals of C, but they liked the more detail on the text one. What you will see is if you search on the internet, although SEEP is an internationally recognised tool, you find lots of versions of it. So I'm sure if you Googled, you would find a version with the subcategories with pictures. But because the subcategories are about symptoms as well, actually the visuals work. And again, if you're dealing with patients, you might want to show them the pictures and say, where do you think you are? And we're increasingly doing that, aren't we? Asking patients what their view of where they are is. So visuals are really good. So I think you said you're dyslexic, didn't you? So the visuals are really helpful for people who have some kind of reading difficulty. Might be people who have educational difficulties. There might be all sorts of reasons why the pictures might work better than the words.
Jacqui, our group said as well for nurses that have not got as much experience, so maybe healthcare workers that are seeing patients with these symptoms, actually much easier using the visual one, and then to be able to come to a more experienced colleague and say, okay, I'm concerned this patient's at C3, do I need to go and do more of an assessment? So,
and there's some technical words in there that even registered clinicians, if it's not your area of expertise, you might think, oh, I don't really know what tongue genital is.
And it can overload people as well.
Yes.
Even the sheet with writing on it's like, well,
So, but if you've got a picture of, it's much easier to say it looks a bit like this.
Yeah.
Have to say at the minute, mainly white skin. we need to think about what some of those things might look like in dark skin tones. So start bringing that to the fore maybe a little bit.
Yeah.
But it might be that you can think about with your team of getting your own pictures
Yeah.
of what, you know, your local population, and people relate to that much more, don't you? These are my patients, so remember that was that lady who had that.
Yeah.
Works really well, doesn't it? So how do you think then this would impact care? You know, do you think this would start to make people think about the benefits of early treatment?
Yeah.
Do you think this is something you'll take back?
Definitely, because you know, especially if you've got patients coming in, but also you know, you've got daughters, mums, dads, or whatever, they'll be thinking about themselves.
Yeah.
And you know, you can target them as well at the very start.
Yeah. So if an elderly patient comes in with their
Absolutely, yeah.
child, and you can say,
Yeah.
I see your legs.
Yeah.
You've
Yeah.
got, it's a family thing, because it's often a family thing, isn't it? Yeah.
Yeah,
Good,
yeah.
really good point.
Yeah.
So the client group that I look after, they would benefit from being in like compression. I look after the homeless.
Right.
Majority of them are IV users.
Yeah.
So obviously their vascular system's compromised anyway. Yeah. But I'm having to fight back, so I'm
And
trying.
they're, you know, they're on their legs a lot, aren't they?
Yeah, I'm trying to get a couple that don't have ulcers at the moment into compression, and I'm getting fight back from the surgeries saying
But not from the patients.
no. The patients are happy to go into it.
Yeah.
It's free pair of socks.
You press socks each one.
But it's the surgeries that are fighting back. Oh, we can't afford it. They haven't got a wound.
Yeah.
We have a well leg as part of our leg club.
Yeah.
It tends to be people that come through the leg club and then have their legs looked at every month or so.
Yeah.
But you could easily integrate this and actually say people go along to our well leg part of our leg club, and you know that we could easily.
So on that pathway, remember we have primary prevention and secondary
Yeah.
prevention. Your well leg club's the secondary prevention. But they often bring their partners, don't they? Or if somebody brings them, whether it's the son or daughter, it's that time to be giving that information about, if we'd known about this, if you'd come early. Not to make them feel bad if you'd come earlier, but you know, if we know about these things earlier, we can start at the beginning. We can make your life better. We can prevent leg ulcers happening if we know about it. And it takes away that burden on society. And that burden on us as a workforce. And it's quite nice to be able to do something positive, isn't it? Although it's very difficult to measure. You can't measure things that don't happen. That's the big thing with pressure ulcer prevention. We don't know how many patients would have got pressure ulcer. So costing it's hard. But if you see somebody whose whole family history, their whole medical history is they're going to get a venous leg ulcer, and they don't, that's a win. And how much of your work now is a win? It's mainly just day to day.
That is, yeah.
So it would be really helpful if we could start to think a little bit more proactively, and whether it's a leg club or a leg ulcer clinic or a foot clinic where you're seeing people, you know, where they've got, because of motor neuropathy, they've got collapsed feet and they've got poor joint mobility, they're losing that calf muscle pump activity, so they're getting poor venous return, that we should maybe be thinking about compression, early use of
I
compression.
almost feel like, especially when you hit the GP, you know, they're coming in for, I don't know, cut on the head or whatever, and they're looking at them going, notice your legs are swollen. You know, it's almost
Yeah.
like you just want to get them pointed in
And
the
that
right
early
direction.
assessment, GPs are always a blocker, aren't
They
they?
are.
Because they look at what the patient comes in for.
Yeah,
But
exactly.
think how many patients go through a GP surgery for a repeat prescription for a chronic, long-standing condition,
Yeah.
and the only person they see is a GP, none of you.
Yeah.
And then the first we know about is they get a leg ulcer or they get a pressure ulcer.
So,
That general practitioner must have noticed that patient used to walk in,
yeah.
and then they got a stick, then they got a frame,
Yeah.
and then they get wheeled in.
Yeah.
But it doesn't, skin integrity, skin harm, is not in general practice language.
No, exactly.
And if we did more preventative care, prevention of skin harm, you know, and this prevention is, it's not all about intravenous ablation, it's about exercise, it's about moisturise your legs, wear compression. And if you meet those criteria, let's get you in early for endovenous ablation. But there's so much more we can do in terms of public health medicine.
I think an interesting one, because you can argue about the funding, can't you? And I think a lady over here said you're struggling because the GPs are saying, well, they've not got wounds, we haven't got the funding to put anybody into prevention. You know, some patients, all patients can't afford to pay to go into compression, but a lot of patients can.
and
You know, and they would if they just knew about it. I was telling a story to Jacqui and Magnus. My dad is in his late 70s now. He spent all of his career in jobs that he's either sat down or he's stood up. He was a postmaster for a long time running a rural post office. His veins, his legs are horrendous. It's taken me 10 years of saying to him, Dad, you are going to get a leg ulcer. You're going to knock your leg one day and you're going to get a leg ulcer, showing him pictures. Because he doesn't want to wear girls' tights.
Yeah.
And he has to wear thigh legs because his varicose veins are so pronounced on his leg. But he now pays for them. He pays for them, and the relief you get, I can't get him out of his girls' tights now.
They do, some companies do men type socks, but it's
That's what he has. So he has thigh legs.
struggling to get them through.
And then they were talking about, because modern medicine is not geared up to prevention. You know, doctors aren't taught that. It's like all the thing about the menopause and people being surprised doctors didn't know about it. But menopause is not an illness, and they're trained in illnesses.
Disease management.
And so we're coming at it. I mean, I'm with you with the GPs. I can't even get them garments for chronic lymphedema from GPs. They're a real block.
Yeah.
And there are segments of society we could work with. So one of my colleagues is Chief Nursing Officer for North West Police Force. And I was like, it's an interesting job. And she spends a lot of her time with the traffic police, doppering them and putting them in compression. Because they're either sat in the police cars all day, so think about the compression on the femorals, or they're on the motorbikes like that all day, compressing the femorals. And they get really bad venous return. So she's getting them all into compression, she's getting them all aware of the signs and symptoms of venous disease, and they're starting to moisturise their legs and do all sorts. But there are other bits. You think about posters, but they walk a lot and they get a lot of exercise.
Lovely legs.
There's other groups.
Hairdressers, school teachers, dentists,
Shop assistants.
nurses, postmasters, GPs.
Yes.
Allied health professionals included in clinicians. So we could do some really good work, and the Legs Matter campaign is very much about that, isn't it? Which Leg Club supports. So we have lots of opportunities to raise awareness of these early stages of venous disease, not venous leg ulcer. So go back, have a look at your pathways, have a look at your assessment forms, and think about what you can do to improve